Hello, and thank you for the opportunity to present our work on early COVID respiratory risk stratification using machine learning. During the COVID-19 pandemic, it has become common for patient needs to exceed health system resources. Clinicians then are forced to use judgment about which patients are most likely to require hospital and ICU resources. We sought to develop an objective tool to help with the triage of patients with COVID-19. We focused on the question, which patients will require intubation within the next 48 hours? We obtained a data set of 3,447 patients from 3 academic medical centers in Arizona. 20% of these required intubation. Time series data, including vital signs, lab values, and oxygen requirements, were chunked into 4-hour time blocks, with each block labeled as a case of intubation within the next 48 hours or not. To explore which combinations of parameters were most predictive of intubation, we used LASSO, or least absolute shrinkage and selection operator, a regularized linear method, and XGBoost, or extreme gradient boosted trees. The cohort had an average age of 49 and was 51% female. The most common comorbidity was diabetes. Here are the results for LASSO. We initially tuned the regularization parameter to identify the 10 to 15 most significant predictors, then used an elimination algorithm to narrow the model to the final 6 parameters shown here. They're plotted against their weights, and you can see that FiO2, or the fraction of inspired oxygen, was the most important predictor. The model is implemented by summing the product of each predictor with its weight. The receiver operating characteristic curve shown at the right achieved an area under the curve of 0.8 and a negative predictive value of 99.7%, indicating a very low rate of under triage. These are the results for XGBoost. We initially focused on the sparse model of a single tree. This achieved an area under the curve of 0.74. You can see in this representative segment of the larger tree diagram that the multiple splits allow the model to capture intricacies and dependencies that a linear model cannot. If we allow the model to become more complex, i.e., so the final output is predicted from the combination of 100 separate trees, the area under the curve improved to 0.86, and sensitivity was 99, specificity was 74%. Once again, the FiO2, or inspired oxygen, was the most predictive feature. In conclusion, we explored 2 methods to create the early COVID respiratory risk stratification score. Of these, XGBoost was by far the more complex, but also more accurate in terms of sensitivity and specificity. However, as our objective was to create a rapidly deployable, clinician-friendly bedside scoring tool, we present LASSO with its combination of just 6 parameters and high sensitivity as the final E-course score. We would like to highlight that one of the barriers to using a more complex and potentially more accurate score in the healthcare setting is that many of the EHRs are a closed system, such that clinicians are required to type values into an external calculator to use a predictive model. We're hopeful that continued collaboration for machine learning in healthcare will allow implementation and testing of models within the EHR environment so that complex and accurate models can become accessible to clinicians at the bedside. Thank you.